Well, hello, everyone. I'm Dr. Jacqueline Smead, and I'm so excited to be here with today's guest. Welcome to the December Dutch webinar. First things first, we want to inform you that we are running a promotion from now through December 19th of this year, 2025, exclusively for registered Dutch providers. Now, if that's you, you're eligible for the biggest discount we've ever had on test kits, which is half off up to five Dutch Complete or Dutch Plus test kits. You can visit dutchtest.com/order now to learn more. This is in celebration of our new report. But now on to today's webinar. In today's webinar, I'm really excited to welcome Dr. Sara Szal, who's going to be exploring Menopause 3.0 and how to really modernize menopause care. Now, her presentation critiques the status quo of menopause care, highlighting the gaps that we have in research, in provider training, and in access, and argues for a more proactive clinical model that really empowers women as partners in their healthcare decisions. It emphasizes the role of bioidentical hormone therapy, lifestyle interventions, and advanced testing to optimize longevity, brain health, cardiovascular resilience, sexual function, and of course, metabolic stability, so important after the age of 40. A little bit about Dr. Sara, for those of you who don't know, Dr. Szal is a Harvard-trained physician, scientist, and researcher with over 30 years of experience specializing in precision and functional medicine with a focus on women's health and longevity. A four-time New York Times bestselling author, amazing, she brings deep clinical expertise together with a personal health journey to really create individualized root cause protocols that look at genomics, biomarkers, the microbiome, metabolic health, and lifestyle. Now, if you're ready to start using Dutch testing in your practice, sign up to become a registered provider today. Click the link we've posted in the chat and complete our provider application form. Registered providers gain access to our entire educational library, including our provider-exclusive courses, our resources, and one-on-one consultations with the Dutch clinical educators. Please note, before we get started, the contents of this webinar are for educational and informational purposes only. This information is not to be interpreted as or mistaken for clinical advice. Please consult a medical professional or a healthcare provider for medical advice, diagnosis, or treatment. And lastly, if you have any questions as we go, please submit them, and we're going to do our best to address them in a follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. Be sure to follow @DutchTest and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts. Now, it's a true pleasure to have you with us today, Dr. Sara. You are a beloved colleague and a friend of ours, and we are so excited to hear what you have to say. So let's take it away.
Thank you so much, Dr. Jacqueline Smeaton. I feel like you and I have known each other many, many years. I just love my work with you, and
Likewise.
and thank you to Dutch for sponsoring this webinar and for being the leaders when it comes to hormone testing. I especially want to thank Mark Newman. Your friendship over the years has really meant a lot to me. So I'm going to share my screen. Hello, everyone. Super excited to be with you today and to talk about menopause and perimenopause, which is a topic that I've been somewhat obsessed with for about 30 years. Even when I was in my 20s, I felt like there's such an unmet need when it comes to women over the age of 40. So delighted to be talking about this today. And I want to mention also that longevity is such a huge topic. It's great to see it trending right now. I'll be talking about longevity and how that fits into a conversation about perimenopause and menopause. So I want to start with some sobering information. First, we know that 1 in 3 women die from either a heart attack or a stroke, a myocardial infarction or a stroke. And so that's one woman every 3.5 seconds who is dying from cardiovascular disease globally. So over the next minute, that's 17 more women who will die. And over the next 60 minutes, you can imagine this number is huge. It's 500 plus women. We also know that the prevalence does not affect different races equally. Non-Hispanic Black women are especially at risk. So let's talk about where we are with status quo menopause care. I feel like I've spent my career trying to change the status quo, and I want to share with you today what I feel like we need to move toward. So, status quo menopause care is that women are asked about hot flashes and night sweats, and that's if they're asked. So, we know that about 75% of women who seek help and treatment for menopause care don't get it. They don't get asked about the 100 plus symptoms that they can experience, from itchy ears to brain fog to changes in libido to lower energy because estrogen is not regulating the mitochondria like it once did. We know that the biology of menopause and perimenopause is universal. And of course, that includes declining ovarian reserve, which Dr. Smeaton is such an expert at. But the personal experience of a woman varies enormously. Um, And this part never ceases to amaze me. So, even though we know what's happening in the female body, there's a way that a woman's experience gets dismissed or denied or not fully seen and appreciated. So, that's part of the status quo that we need to change. We know that the nature and severity of symptoms, we know the range from psychology to endocrine changes to metabolic changes to social and contextual considerations. All of that needs to be understood for an individual woman. We know that this area is underfunded, there's lack of research, lack of knowledge. And the part that makes me the most sad is that when I think about our primary care colleagues, and I think about the people who came through their medical training, and maybe this is true of your primary care doctor, those who came through their training around 2002, when the Women's Health Initiative was published, basically stopped paying attention to the treatment of perimenopause and menopause. And so we've got this whole generation of primary care doctors that lack information and confidence in prescribing hormone therapy. So that's what we need to change. Thankfully, we've got Dutch supporting us with education on this particular topic. So there's more than 100 plus symptoms that women experience. It can start as early as your 30s, depending on how careful you're paying attention. So for women who are 35 and they start to notice that their menstrual cycle maybe is getting a little bit closer, maybe they notice a metabolic change. They're having more mood swings, breast soreness, irritability. Irritability is one of the most common psychological symptoms that women experience in perimenopause. So there's 100 plus symptoms. The things I tend to highlight and ask about include: are you satisfied with your sex life? Are you noticing that your sexual interest and desire has changed? What about nervous system regulation? We know that the balance between the sympathetic nervous system and the parasympathetic nervous system, so fight, flight, freeze, fawn, versus rest and digest, feed and breed, stay and play, the balance between the two becomes dysregulated as estrogen declines. And estrogen tends to start to decline around age 43, as illustrated in this graphic. So the nervous system piece is one that I've been thinking a lot about. I'm writing a new book about female longevity, and I feel like it's such a critical part of this picture. And I'm also obsessed with wearables. I'm obsessed with how do we use technology to help women have a window into this experience of perimenopause and menopause. And we know that heart rate variability is a really accessible metric that you can use to track some of these changes. So if you're not measuring your heart rate variability, I hope by the end of this talk, you're convinced that you should be, because HRV tends to bottom out. It tends to tank right around perimenopause. So there's an accelerated decline, not in all women, but in the ones who aren't paying attention and aren't addressing it. And there's so much we can do about it. So we'll talk about some of the solutions as we get to that point in this presentation. So I spoke about the Women's Health Initiative. I feel like it is the wrong study at the wrong time in the wrong women with the wrong hormone therapy, synthetic hormone therapy that is structurally very different from what women have produced throughout their reproductive years. And the way I like to frame the Women's Health Initiative is aligned with Barbara Levy. So she says, findings from the Women's Health Initiative, which treated a population of older asymptomatic patients. So these were patients who were not having those 100 plus symptoms of menopause, mean age 63. This study, the Women's Health Initiative, WHI, has been extrapolated over the past 21, 22, 23 years to all estrogen products, all menopausal women, all forms of progesterone, and all delivery mechanisms. Our patients deserve a more nuanced, individualized approach. So you may have heard Peter Attia talk about how medicine has evolved. So he talks about medicine 1.0, which is mostly acute care. It's doctor-centered. Physician autonomy is a critical part of it. Small medical practices, doctors decide treatments and fees. That then evolved into medicine 2.0, which was what I trained in starting in 1989 to 1998 when I finished my obstetrics and gynecology residency. So this is more reactive medicine. It's about big medicine, big pharma, the hospital system, health maintenance organizations, disease management, a pill for every ill, profits at the expense of health. And it was technology and diagnostic based, data based, but it's very different from the kind of medicine that we now need, which is medicine 3.0, proactive, personalized, participatory, and preventive. So I'm going to build on this concept as we move along, but when I talk about menopause 3.0, I'm talking about it in the context of medicine 3.0. Now, another point about menopause 3.0 is that women outlive men. So on average, women outlive men by about 6 years. It depends on your zip code. But what we know is that women tend to have an advantage with almost all of the major causes of death, except Alzheimer's disease. That's one condition where women have an outsized risk, so double the risk compared to men. Now, there was an article in which I was featured in the Wall Street Journal, and I really appreciate how the Wall Street Journal is tracking some of the changes in our culture. And so the title of this article by Amy Marcus is Step Aside Longevity Bros. It's time for the longevity ladies. Now, I don't love that branding. If you have ideas for how to brand the interest and enthusiasm and groundswell of support for longevity that's specific to women and not just what's proven in the longevity bros and assumed to apply to women. If you've got some ideas for branding, let us know in the chat. I want to hear about it. But it's exciting to see those start to shift. So I wrote my first book about longevity almost 10 years ago. And at that time, there wasn't much of a conversation about longevity. But what's happened is that millennials are super interested in longevity. They're interested in health and wellness at numbers that are far larger than Gen Xers or baby boomers. So it's really exciting to see millennials kind of drive this change, and for female millennials, it's great to see female millennials say, okay, this idea that you tell me to cold plunge or to fast and the data is based in men, or even to take a sauna and the data is based on finished men, like I want to know if that applies to the female body. So there's a trend that I get very excited about, which is this emphasis on female longevity. So a few more statistics that I want to share with you. So we know when you compare men and women, there's this idea that women do better in terms of cardiovascular disease or even cardiometabolic disease, but that is not true. So at equal age, women have more consequences from cardiovascular risk factors. We also have this stress test called pregnancy that a lot of us fail. So I had a borderline test for gestational diabetes, and that was the first indicator that I had of a problem with my cardiometabolic system. And so I've had to work to address that, which is a big part of the content that I create. We also know that even though women are quite reasonably fearful and concerned about the risk of breast cancer, 7 to 10 times more women die from cardiovascular disease or stroke compared to breast cancer. We know for younger women that there's higher rates of prediabetes and undiagnosed diabetes that we're seeing, especially over the past 20 to 25 years. And even though men have done better in terms of outcomes from cardiovascular disease, heart attacks are actually climbing in women age 35 to 54. So there's a myth that women are not at risk for cardiovascular disease until after the age of 55, and it is utterly untrue. So we have more metabolic dysfunction. About 93% of Americans have metabolic dysfunction, at least one of the signs of metabolic syndrome. And this has led to much greater risk among younger women. We also know that there's not just sex differences, like smaller coronary arteries and a different immune system in women, more risk in terms of prediabetes in women compared to men. There's also gender differences. So sex differences are biologically constructed. They're based on chromosomal and other differences. But there's also gender differences, which are socially constructed. And so if a woman is having a heart attack and she goes to the emergency room, if she sees a male physician versus a female physician, her survival is 2 to 3-fold different. I just want that to sink in for a minute. So the sex, the gender of your physician that you see in the ER makes a 2 to 3-fold difference in your survival. And in that same study, they looked at men who presented to the emergency room. And if they saw a female physician versus a male physician, their survival was the same. So that is a marked gender difference that we have to address. We have to address it through education and also through patients being aware of this and demanding better care. Female patients demanding better care. We also know that hormone therapy causes no harm to younger perimenopausal and menopausal women. My attitude is start as early as possible. Start when you begin to see a decline in progesterone. Start when you start to see estrogen fluctuating wildly and sometimes low. So start in perimenopause. Don't wait until the final menstrual period. So let's go over some Menopause 3.0 concepts. The first is we think of these hormonal changes as being the primary mechanism behind perimenopause and menopause. But here's the truth. There is a gigantic immuno-metabolic change that's happening. Now, hormones have a lot to do with it because estrogen drives metabolism, it drives insulin sensitivity. It's part of the reason why, as indicated here in the dashed line, glucose metabolism declines from premenopause to perimenopause to postmenopause. The immune system also changes. So you can see illustrated here, the innate immune system declines in perimenopause, and then it gets back to pretty close to its baseline level postmenopausally. The adaptive immune response reaches a peak in perimenopause. That's why we tend to see so many vaccine reactions in women who are in perimenopause. So there's this huge immuno-metabolic change that's happening, usually below the radar. We also know from recent data, this is a study published in Nature Aging, and for the clinicians who are on the call, I really encourage you to take a look at this particular study. So this was published by Michael Snyder's lab at Stanford. And we tend to think of aging as this linear process, that you just kind of slowly, year after year, as you start to notice wrinkles and changes in your skin, that there's this sort of stepwise process. But it turns out that aging is nonlinear. And there's two waves that really stand out. So there's a spurt of aging that happens around age 44, and then another spurt that happens at 60. So this affects a lot of different pathways, like the ones I've mentioned already: your immune system, your metabolic system, your cardiac system, your kidneys. And when you look at these changes from a multi-omic perspective, it then gives us this Menopause 3.0 perspective about how we could be addressing it. So in my mind, it's not quite as simple as perimenopause. If a woman is a candidate, start her on hormone therapy, estrogen, progesterone, maybe testosterone if she needs it. It's broader than that. We want to be thinking, how else do we support the mitochondria? How else do we address glucose metabolism and the insulin sensitivity? How else do we support the circadian rhythm? So I want you to be thinking about these nonlinear changes that happen with aging, and how do we address them before age 44 in our female patients? To me, that's a big part of the Menopause 3.0 conversation. Now, another huge factor is the brain. And in my mind, especially as the daughter and the granddaughter of someone with Alzheimer's disease, in my mind, the female brain is the most compelling reason to see if someone is a candidate for hormone therapy. And one of the things I won't shut up about is that I believe 100% of women deserve counseling about hormone therapy. Now, they may not all choose to do it. They may not be candidates. They might have absolute or relative contraindications, but 100% of women deserve counseling. So a big part of why I think that's the case is shown here. And this is cognitive function throughout premenopause, and then it starts to decline in perimenopause, and then it declines further postmenopausally. Now, those of you who are on this webinar who've had children, you know that it's not quite a straight line in premenopause. There tends to be a little dip that happens where you lose about 2% of your synaptic connections and total brain volume when you're postpartum. Postpartum, of course, is a preview of coming attractions in perimenopause. So it's not always stable in premenopause, but perimenopause is a time of dramatic shift. And I want to show you some of the data to support this. And we know that if you start early hormone therapy, so not waiting until 10 years after menopause, but starting hormone therapy sooner, can really make a difference. It can potentially get you back to your baseline. If you wait too long, like they did in the Women's Health Initiative, and you start hormone therapy way out here at a mean age of 63, that can actually accelerate decline, and we don't want that. So let me give you a couple of definitions as we go a little bit further for those who are on the call who are maybe patients or potential patients, not providers. Everyone is welcome here, and I'm so glad you're here. Perimenopause is defined as around menopause, and I track it very carefully in my patients, usually starting in their 30s. It can last for 10 to 20 years. I just went through menopause for the first time at age 58. We know that menopause is defined as a year from your last menstrual period, but you can also define it chemically by measuring a follicle stimulating hormone in the blood. And so an FSH level of 25 or higher is the biochemical definition of menopause. You can also see premature ovarian insufficiency in women who are under the age of 40. I take care of a lot of these patients. Dr. Smeaton, I imagine you do too. Early menopause is when you have this change in FSH and you have symptoms of perimenopause and menopause between 40 and 45. Now, one of the cool things about hormone therapy is that recently it's been shown to address biological age. So it can help, if you look at your chronological age and you look at the biological age of your body, hormone therapy can address biological age. So the scientific way of describing that is that it decreases phenotypic age acceleration. So I've included some citations on that in the deck. So let's talk a bit about brain changes associated with perimenopause and menopause. There was a fascinating study that was published back in 2018 in the Journal of Neurology from the University of Texas at San Antonio. And they looked at about 2,000 people from the Framingham Heart Study, the Generation 3 participants. And these were men and women in their 40s. So they were not old, they were 48. And they found that in this population, they measured cortisol levels, salivary cortisol levels, like Dutch measures. When the salivary cortisol level was high in the morning, they saw that this was associated with worse memory and also visual perception. It was also associated with decreased occipital and frontal lobar gray matter volumes. Now, there were also some sex differences. So they found that women who had high cortisol had shrinkage of the brain. Their total cerebral brain volume was declined. So it was lower compared to the men who had high cortisol. So this is one of those studies where I was like, okay, so high cortisol levels in the morning, salivary, is associated with brain shrinkage at an age of 48. I'm kind of screwed because every time I check my cortisol through my 40s and 30s, my cortisol first thing in the morning, my cortisol awakening response was high. So if you have not measured your cortisol awakening response, I hope you will do that. You'll take it as an action item today. Now, Lisa Mosconi at Cornell, a good friend of mine, has done some additional studies that I think are really important to understand. So she's looked at PET scans in women in premenopause, perimenopause, and postmenopause. And here's what she's found. So if you look at the premenopause brain on the left, you'll notice all the red areas, the red and yellow areas. Those are areas of high metabolic activity. So these are PET scans, and the PET is measuring glucose uptake inside the cells of the brain. So look at that premenopausal brain. Look at how much red and yellow there is. And then let your eyes shift to the middle brain, the perimenopausal brain, and notice the decline in the red and yellow areas. So there's about a 20% decline. And then postmenopausally, there's a further decline of those red and yellow areas. So overall, about a 25% decline in how the brain picks up glucose, leading to symptoms like brain fog, a slowdown in brain energy, a processing speed that's not quite what it once was, a decline in memory, short-term memory. So all of these things are really common, and about 80% of women experience this. So the official name for it is cerebral hypometabolism. That's kind of a mouthful. The way I describe it to my patients is, hey, have you noticed since your early 40s that there's a slowdown in your brain energy? And I get this nod back because it is so common. 80% of women experience this. I myself have experienced this. It's what led me to write a book about the ketogenic diet for women as a way of trying to work around this particular issue with a decline in glucose metabolism, not just in the body peripherally, but also centrally in the brain. So here's Lisa Mosconi. She says, if you look at the brain scans of men and women at midlife, their 40s through their 60s, the women show more plaque, more brain atrophy, reduced connectivity, and reduced glucose metabolism. We should not think of dementia as a disease that starts in old age. It starts in middle age. And middle age, my friends, starts at age 40. Now, recently, 2024, Lisa confirmed the study that was published from the University of Texas, San Antonio, and she showed that in 277 cognitively normal midlife people, men and women, that higher cortisol was associated with lower total brain volume, lower glucose metabolism, and more amyloid beta load in the Alzheimer's disease vulnerable regions. So this is really important to understand that it's not just the aging process that we want to be thinking about. In Menopause 3.0, we want to also be thinking about these other hormones. We want to be thinking about cortisol, thyroid. We want to be thinking about estrogen, progesterone, testosterone, and we want to be thinking about the metabolism of these hormones. So Roberta Brinton is a PhD at the University of Arizona who says, with aging, there can be a decline in the brain's ability to generate the fuel it needs. The key is maintaining the body's system of glucose metabolism, and that entire process in women is regulated by estrogen. And so much of it is governed by the mitochondria. So another issue to consider is that mental health tends to reach a low point, 45 to 55. So not only should we be asking about sleep, hot flashes, night sweats, weight gain, changes in metabolism, what's going on with your fasting glucose, what's happening with your 2-hour glucose challenge test, what's happening with your immune system. We also need to be asking about mental health, suicide, divorce. So you might have heard about how divorce rates spike in this age group, 45 to 55. I've been writing a lot about this on my social channels because I went through a divorce a couple years ago. So I I'm not going to get into the details of this, but I just want you to be paying attention to the fact that so many of these symptoms, the nervous system dysregulation, um, the other positive aspect of this is that I believe women are uniquely neurobiologically primed for awakening 45 to 55. If we can see it that way. So that's not our conversation today. It's not the topic, but let me know if you have any questions about that. I'll leave it at that. So let's talk a bit about hormone therapy. We're going to start to get into some of the solutions. I am a big fan of hormone therapy. I won't shut up about it because I think 100% of women deserve counseling about it, and they deserve testing to make sure that they've got the right fit. It's not as simple as, do you want to take hormone therapy? Yes or no? It's an ongoing negotiation. Are you getting the right type? Are you at the right dose? Is it having the biological effects that we want to have? How are your mitochondria doing? What's going on with your cardiometabolic system? So there's all these different indications for hormone therapy. Now, when I first started working with hormones back in 1989, when they unleashed first year medical students on these poor women, and I started thinking about hormone therapy, mostly for my patients, but also for my mother. At that time, we really only thought about them for vasomotor symptoms. So hot flashes and night sweats. And still now, if you look at the North American Menopause Society, their guidelines are centered around treating vasomotor symptoms. Now, I have never had a night sweat or hot flash in my life. That's not why I take hormone therapy. It's not why I started hormone therapy in my 30s. I started it for mood. I started it for sexual dysfunction. And I continued on it because I wanted to support brain health. There's also the indication of the prevention of osteoporosis. And increasingly, because of the effect on biological age, you could take hormone therapy for health span reasons. So there's a lot of different reasons. I don't have all of them listed here. What about insomnia? Women have double the rates of insomnia compared to men. And it tends to start either when you're postpartum and everyone tells you to sleep when the baby sleeps. And a lot of women find that they can't because they've got no estrogen. Another indication is so in someone who's got insomnia or difficulty sleeping, I usually use a continuous glucose monitor. I'll start them on progesterone if they're a candidate. Most women are. That might be oral progesterone, depending on their metabolites, or it might be vaginal progesterone, which is a whole other conversation. So lots of different indications for hormone therapy. And I just want to make the point that a lot of these guidelines that we have, like the 2022 North American Menopause Society guidelines, don't go broad enough in terms of what we should be treating. So we've got to demand a change here as part of Menopause 3.0. This is the assessment that I do for my patients. Now, I work at a university. I also have a private practice. And what I do is a little broader than what other people do in practice, but I don't do healthcare maintenance anymore. I refer patients to their primary care or concierge doctor for that. But I do a lot of serum biomarker testing. I do coronary artery calcium scores. I do whole body imaging. And I certainly do dried urine testing for checking the control system for your hormones, the hypothalamic, pituitary, adrenal axis, as well as thyroid function, gonadal function, and the role of the gut. I do salivary cortisol for the cortisol awakening response, the so-called CAR, and the diurnal pattern. And then I do, this is discretionary. I do genomics. I do a lot of Intellex DNA on my patients because I've got a lot of patients who come to me with a family history of Alzheimer's disease or dementia, and they want to preserve their cognitive function. I do a lot of nutritional testing, looking at micronutrients. I do gut function testing, biological age testing, cognitive testing, exercise performance like VO2 max, grip strength, lactate threshold. And then I use wearables in my patients. And I think what you're going to see over the years to come as part of Menopause 3.0 is the integration of all of these data streams so that you're able to manage it with the assistance of artificial intelligence. So there's a long list of all the things that are beneficial with bioidentical hormone therapy. I'm not going to get into the details of this. Maybe you'll come to the A4M Longevity Conference. Is that next week? I think it is, where we talk about some of the benefits. But nothing works like hormones do for vasomotor symptoms. It also, when given early enough, and that's why I do coronary artery calcium score in all of my patients at 45 or earlier if they've got premature heart disease. We know that it helps to prevent subclinical atherosclerosis. It stabilizes the endothelium. So women who have hot flashes and night sweats, if it's untreated, we know that that can be associated with disruption of the endothelium, the lining of your blood vessels. It stabilizes bone density. It helps with the genitourinary syndrome of menopause, also known as vaginal dryness and irritation and recurrent bladder infections. Helps with brain health. As I said, I think the most compelling reason to give bioidentical hormone therapy. It helps with sexual interest and desire. Now, sometimes the problem is the relationship, but in really good, secure attachment, healthy relationships, hormones can drive about 70% of decreased sexual interest. We know that hormone therapy is associated with decreased breast cancer mortality. Now, the synthetic hormones are associated with a greater risk, particularly progestin. We also know that bioidentical hormone therapy reduces the progression to diabetes, and it helps the skin. So I have a particular blueprint that I use in my patients. I like to track vasomotor symptoms. I use 8 Sleep. I use Aura. I'm also testing Whoop and Ultrahuman looking at this. I track sleep in all of my patients. I like to track mood and cognition over time. I track body composition. I imagine you do that too. And VO2 max and grip strength. It's amazing. Grip strength takes a few seconds to measure. If you don't have this in your practice, please add it because it is so predictive of the process of aging. So I really want to be using it more in women, and it should be part of Menopause 3.0. There's a lot of labs that I like to look at. I tend to start with serum testing, and then I back it up with dried urine testing. I do a lot of advanced biomarker testing. You should do, the I like to measure lipoprotein little a in all of my patients. And for patients who got a level that's elevated in their 30s and 40s, I like to check it again in perimenopause and menopause because it can go up. I look at metabolic function. I look at thyroid function. Women so commonly are low in iron and have low ferritin, and that's driving their decreased energy. So we have to address that. And then I do risk stratification. I do coronary artery calcium scores. I do clearly in patients, if I have a high index of suspicion, a CT angiogram. And then I like to do risk profiling. So I've got some information about breast cancer risk. Unfortunately, we're pretty limited in terms of bioidentical hormone therapy and randomized trials that are long enough to look at the breast cancer question. We know that if you have a small breast cancer and you get started on hormone therapy, it could make it grow. But we just want to make sure that when someone starts hormone therapy, that they've got a digital mammogram or some additional quantitative test that puts them in the clear before they start hormone therapy. Now, I've written a number of books about perimenopause. They're shown here. The Hormone Cure is my first book, then Women, Food, and Hormones, which was a way of addressing this brain fog issue that so many women experience over the age of 40. And then my latest book, The Autoimmune Cure, I recommend that if you have an elevated anti-nuclear antibody or you've been diagnosed with either pre-autoimmunity or autoimmune disease. So this is my intervention blueprint, and I'm just going to spend a couple minutes here wrapping up, and then we'll take your questions. So feel free to put those into chat. So my intervention blueprint, this is basically part of the table of contents of my next book. So I think you start first with lifestyle medicine. I think of this as base camp. So you start first with your circadian rhythm, since that's what sets the tone in the body, and it's so important for the female body. And it's driven by cortisol as well as melatonin. So I like to measure both of those. I like to really focus on stabilizing the sleep wake cycle, getting morning outdoor light. Women seem to need more than men do. So my friend Andy Huberman talks about 10 to 20 minutes of outdoor light in the morning. Women need like 30 to 60 minutes. So this is one of those situations where you really want to be relying on data in women, not data in men that's assumed to apply to women. Exercise. Exercise has such a huge effect on the aging process. It has such a huge effect on perimenopausal and menopausal symptoms. I like to get my patients to measure their zone 2 each week. And I like for them to start. I use this or I use Whoop to measure zone 2. I like them to start at 150 minutes of zone 2 training, build up to 300 minutes per week of zone 2, and then to also really focus on, once that's dialed in and consistent, to then do VO2 max training and heavy weightlifting. There's some nutritional concepts here like omega-3s and lycopenes, polyphenols to support mitochondria in menopausal women. Protein is so critical. That protein signal, getting your ideal body weight as the number of grams of protein each day. It's a lot of protein, but it's such an important trigger for muscle synthesis. And over the age of 40, we lose about 5 pounds of muscle and gain about 5 pounds of fat. And so you've got to change that signal. And then hormone therapy. This is where we need shared decision making. And of course, it has to be anchored to the personal risk of the patient that we're counseling. And then autonomic load. Because there's so much nervous system dysregulation in women over the age of 40, I'm a huge fan, as part of base camp, to really be addressing autonomic load. Now, I want to mention a friend's study. This is Kara Fitzgerald's study. She looked first at men, and she did an 8-week methylation lifestyle study and showed that she reduced biological age by 3 years in men. And I was like, Kara, where are the women? You have to do the study in women. So she did. She published it, I think it was last year. And she showed that in 8 weeks, she was able to lower biological age in women by 4.6 years. She had one woman who reduced her biological age 11 years. So this is with a particular way of eating, with exercising, sleeping 7 hours or more every night, and having a breathing process. There's also some supplements that she recommended, so you can see more on her social or pick up her book. So I'm just going to wrap up here with a summary, and then we're going to take your questions. So first, I hope you now understand that perimenopause is the most volatile and symptomatic period in the female life cycle, and it's marked by aging acceleration at age 44 and 60. So even though the physiology is universal, we have to really tune into the individual experience. There's also a time this is the time of decreased cerebral metabolism that we can address with hormone therapy and also with addressing cortisol issues and supporting mitochondrial function. So we need Menopause 3.0. Every single woman deserves consideration, counseling, and treatment. We've got this opportunity together to reimagine, reshape, and revision our second half of life in a state of self-regulation and co-regulation. So with that, I want to thank you and invite Dr. Smeaton back so that we can take some of your questions.
Thank you so much. You really do just such a beautiful job, like succinctly summarizing the state of where we're at and like speaking on behalf of women for what we need. I'm really just very grateful for how well you pulled that all together for us.
Thank you so much. Thank you.
There were some really great questions in the chat. It was actually hard to pull out just the best ones because there were so many great ones. One that came up that we haven't touched upon, but I think is so relevant and on the minds of a lot of providers today, is the role that you think that GLP-1 and other kind of peptide medications could have. I know you've talked about that before on social. I'd love for you to share your thoughts about, I know not all of these things have been borne out in evidence-based research and, controlled trials, but what are you seeing in your practice? What role might these medications have to play for women in your view of menopause?
Yeah, this is a huge topic. I'm going to launch a Substack beginning with this particular topic because probably half my patients right now are on GLP-1s. And what I see is that while there's great promise, it certainly helps with insulin sensitivity. It helps my patients with prediabetes and diabetes. It addresses that huge metabolic dysfunction that women in particular experience. I also think they're overused. And so there's this vast uncontrolled medical experiment happening where I see a lot of women who are normal weight and healthy weight feel this social pressure to go on a GLP-1. Yeah. And that concerns me because I feel like whenever a blockbuster drug comes out, there's all this hype and all this enthusiasm. People start it, and then it takes 5 to 10 years before you really start to see some of the side effects. So I think there's time and a place for it. I think the cardiovascular benefits, the cognitive benefits are really impressive. But I get worried, especially, I've got 2 daughters, and I get worried about the pressure they feel to go on GLP-1s. So I'm hoping that I'm doing an IRB right now to be able to track outcomes with microdosing GLP-1s. I think that's something that's coming. In general, I think peptide therapy, of which GLP-1s are part of peptide therapy, has an important place in longevity care in Menopause 3.0. But I'm also cautious and evidence-based. Anything you want to add, Jacqueline? What did I leave out?
No, I really agree. I mean, I think that there's such profound improvement for individuals who have high cardiovascular risk, high metabolic risk with weight coming down.
Yes.
And that's where we see a lot of the benefits with GLP-1 medications. But I think you're right, in the population that don't have those risk factors, one, will they see the same benefits? And two, of course, we talk a lot about the need for maintaining muscle mass and things like that. And we know that GLP-1s, if they're not done with a provider like you or me, where they're getting a lot of counseling on nutrition, that there can be some risks associated with that rapid weight loss. So I think you're right. Jury's out. And 5 to 10 years later, we always know more. So they really can be a wonderful tool in the toolbox when used appropriately. But certainly, I think it's going to be time will tell for us.
Yeah, well said.
We had a lot of questions come in around. Let me summarize this with like the changes that have been coming up with menopause guidelines. So we had numerous questions come in around discontinuing menopausal hormone therapy. When do we need to discontinue it? And also a couple people that chimed in around starting it a little bit later, like in that 8 to 10 year mark. Do you want to talk at all? Because I think a lot of people listening, maybe because some of these changes have happened even just in the last month, around the guidelines being lifted for discontinuation of HRT. Do you want to talk a little bit about that?
Happy to. Well, we finally got the black box warning removed from hormone therapy. So that's a step in the right direction, but I also feel like it's breadcrumbs. Like we just need a lot more progress than just the black box being removed. So, you know, a lot of the guidelines about starting hormone therapy within 10 years of menopause or by age 60 came from the Women's Health Initiative. And you already know my feelings about that. I feel like it's been um, interpreted the wrong way, and used to set guidelines. And I don't agree with those. So in my practice, I do the kind of workup that I showed in the slides, and then we set up N of one experiments. So if I've got a patient who is, say, 65 and 10 years out from menopause, and she's having a delightful, metabolically beneficial, better quality of life on hormone therapy, we're going to look at all the latest data and look at her particular picture to decide whether she should continue or not. And sometimes it's a quality of life decision about whether to continue.
Mm-hmm.
So yes, cardiovascular disease increases, stroke increases as people get older. But, a lot of my patients are taking really good care of themselves. Like they've got the base camp kind of dialed in. They're exercising regularly. They look nothing like the women that were in the Women's Health Initiative. And I feel comfortable continuing hormone therapy in those patients. So I tend not to discontinue unless someone has a rising, coronary artery calcium score, in which case, I'll send them to an integrative cardiologist so that we can potentially reverse it and prescribe hormones more safely.
Wonderful. A lot of people had questions about the testing that you offer, and you're welcome to share like brands and things like that you utilize, nutrient tests, biological age testing. Are there any kind of resources that you'd recommend for people that are listening?
Well, I've used Dutch since it first came out. I mean, I feel like Dutch Plus is my go-to test. So
I love that test.
I love it. I mean, it does the cortisol awakening response, the CAR that we talked about. It looks at estrogen, progesterone, testosterone. It looks at metabolites. And so I do serum testing in all of my patients, and then I augment it with a Dutch Plus. So I think that gives you the best picture of what's going on in terms of hormones. And I do testing, that same sort of cadence of serum plus dried urine. I do that typically 3 to 4 times a year. If someone's stable and they're on a regimen that they're really happy with, then I'll do it twice a year. But I think that's really critical. For biological age, I think the jury is still out on which test is the best. I do a lot of true age. I also like some of the lab-based testing. It's got really good validation behind it. A lot of my patients do the functional test. I don't have any financial ties to them, but I think they use true age. And so I think that can be a really accessible way to get all of these biomarkers done, including biological age, at a pretty good price point. What about you?
I just bought that for my husband for Christmas.
Oh, perfect.
The function health test.
It's the ideal holiday gift.
There we go. Yeah, no, I think that's great. I think the biological age testing is like kind of a newer thing, and I know you've spent the time to really look into it, so I appreciate your opinion on that. I think last question, if we have time for one more. This is a really pertinent one. The question came up around oral estrogen versus transdermal estrogen, and I think they had the awareness that oral had some greater risks associated with it. But is there a difference in effectiveness when it comes to estradiol for cardiovascular, brain health, broader health compared to oral? I know a lot of data is on oral. I haven't seen any data that conclusively says one is better than the other when it comes to improvements. Could you speak to that, or do you know of any?
Yeah, I think the data is quite conclusive that transdermal or topical is better. So
from a safety perspective or an outcomes perspective?
Mostly outcomes.
Both? I mean, safety we know.
Mostly outcomes. I mean, what the North American Menopause Society talks about is how some of the data on fibrinogen, for instance, is better with oral. But I think when you look at the data in totality, I pretty much never prescribe oral estrogen. I really think that transdermal or topical is the way to go.
Great. Thank you.
Yeah.
It's been really wonderful to see you and to have you here. I really appreciate you being part of the Dutch family and spending time with us and with everyone here today. And for all of you that are listening, thank you so much for attending the webinar today, spending your time with us. We know your time's precious, and we're glad you spent it with Dr. Sara and with Dutch. So thank you guys.
Thanks, everyone.